Health is an advocacy organization formed in 2007 with a dedicated mission to furthering the integration of medical and behavioral health care, both in primary and specialty medical settings, as well as specialty behavioral health settings. No Health Without Mental Health believes that integrating medical behavioral health services delivery, provider networks, and payment systems will result in greater access to and the delivery of higher quality, coordinated total health care for patients, and in the process diminish the social stigma surrounding mental disorders. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. Advancing Care Together, a project at the University of Colorado Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program, funded by the Colorado Health Foundation, has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing Dr. Manderscheid and Kathol, I would like to go over a few housekeeping items for GoToWebinar. So you can tune in using either your telephone or computer microphone and speaker, and by selecting the control from the GoToWebinar control panel. And you'll be able to view the presentation through the GoToWebinar viewer on the left-hand side of your screen. Throughout the presentation, you can submit questions by entering in the questions text box. And we'll have about 15 minutes for questions at the end. And I'd like to remind everyone that our webinar is being recorded and will be posted on our YouTube channel, which is available on your screen. Today we are pleased to bring you Dr. Manderscheid and Kathol. Dr. Ron Manderscheid serves as Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. The association represents county and local authorities in Washington, D.C. and provides a national program of technical assistance and support. Concurrently, he is an adjunct professor in the Department of Mental Health at the Bloomberg School of Public Health, Johns Hopkins University, and immediate past president of ACMHA, the College of Behavioral Health Leadership. He serves on the boards of Employees Assistance Research Foundation, the Dana Institute, the Frameworks Institute, and the Council of Quality and Leadership and the National Research Institution. He also serves as a co-chair of the Coalition for Whole Health. Throughout his career, he has emphasized and promoted peer and family concerns. Dr. Roger Kathol is currently an adjunct professor of internal medicine and psychiatry at the University of Minnesota and is president of his management consulting company, Cartesian Solutions. He is a specialist in the care of patients with health complexity, many of whom have concurrent general medical and mental health and substance use disorders. He is board certified in internal medicine, psychiatry, and medical management with extensive clinical and administrative experience gained during 22 years as a physician, teacher, and researcher. He specializes in augmenting the care of patients with complicated comorbid medical and behavioral conditions throughout service and payment integration, and consults to hospitals and clinics, health plans, government programs, and businesses as they develop financially solvent, integrated approaches to medical and behavioral health care delivery. Today, our presenters will discuss the way that medical and behavioral health care is financed, since payment of services drives the way they are delivered. They will walk webinar participants through the historical cross-referral to the current attempted bidirectional model, and then quickly move to a proposed future integrated model. The discussion content will relate to an article published in the Annals of Internal Medicine in January 2014. Welcome to both of you, and I'm going to switch to pull up your slides. And can you both see your slideshow?
Yes, looks fine.
I can.
Great.
Yeah. Ready to go?
We're ready to go.
So Emma, thank you very much. We appreciate being invited to do this webinar. We think this is one of the most important topics that could be taken on in the era of the Affordable Care Act. So we wanted to first do a little bit of backgrounding before we actually get into the overheads of, why is this issue important, and what are some of the concerns with the issue. And I'll start with a few points, and then Roger can add to these points as well. So I think the primary reason it's very important that we work on integration is the fact that we have so many people with behavioral health conditions who also have primary care conditions. And the classic example of that in the public sector are people who are receiving care from specialty behavioral health providers who actually are dying 25 years prematurely, basically because they have no availability to primary care services. And this is not a one-time finding. These findings that I'm describing are from data from about 10 years ago, and the findings have been replicated literally very recently to show that the situation literally has not changed in that 10-year period. So our public sector behavioral health clients are losing 25 years if they are mental health clients. If they also have a substance use condition, the loss of life can be as high as 42 years. So there's a major concern here with comorbidity in this population and premature death. Second point here, in the Coalition for Whole Health, and Emma mentioned that, the Coalition for Whole Health represents currently about 165 mental health and substance use provider organizations. When the coalition was formed, we worked on several principles to guide the coalition, the first of which is people who have behavioral health conditions should have availability to good integrated care delivery. And I guess the third reason here is under the Affordable Care Act, integration is one of the primary features of the movement in the changes in service delivery promoted by the Affordable Care Act, and we'll talk a little bit more about that. And I'll talk just briefly a couple of fears from the behavioral health side and have Roger add here. So a couple of fears from the behavioral health side here are the fact that I think most of our colleagues who operate behavioral health organizations are very concerned about integration for fear that integration will end behavioral health care as we have known it. And I guess I've come to believe over time that nothing could be farther from the truth. In fact, integration is actually very empowering to behavioral health care, and hopefully we can amplify on some of those points as we go forward. So Roger, let me turn it over to you.
Thanks, Ron. And thanks, Emma, for putting this together so that we can share thoughts with the audience. I came at it from a little bit different perspective. Although I do work in the behavioral health sector pretty regularly through the course of my professional career, I also really worked substantially in the primary and specialty medical sector. And so I came at it from the standpoint of there's just a huge number of patients that are seen in the primary and specialty medical sector that are getting absolutely no behavioral health care. And this is really the way that we have set up the health system. In fact, 80% of people that have behavioral health problems are seen only or primarily in the medical sector rather than behavioral health sector and have no access. They're sort of an orphan population that really needs assistance because without treatment, effective treatment of their behavioral conditions, they really have poor outcomes. And it's poor outcomes not just from the behavioral health side, but also from the medical side. We know that diabetics or hypertensives or patients with COPD or the variety of medical conditions that have comorbid depression or anxiety or substance use disorders have much worse clinical outcomes, have worse disability, and have much higher costs as far as total health care. So Ron and I really sort of introduced each other by the common interest in providing services for behavioral health patients. And obviously he has been working primarily on the behavioral health side. I've been working more on the medical side. And I really am pleased to have had an opportunity to interact with him and co-publish this article so that we could raise awareness of the need for behavioral health services really in the primary care sector, and doing the changes to the health system that will allow us to move forward with that, particularly in this age of the Accountable or Affordable Care Act, where there is really tremendous opportunity to do some substantial and important changes. And that's what we'll try to address today.
Okay, Emma, maybe we can go to the first overhead then. Okay, so in this overhead, you see three different models: Model 1, Model 2, Model 3. Model 1 really is, I would say, the model from the past. To solve the problems that Roger and I have described here, the original model that was applied was a cross-referral model. See medical practice on the left, behavioral practice on the right. Someone would come into a behavioral health setting. They would need primary care. The behavioral health provider would refer them to medical practice. We know on volumes of research that that model doesn't work. And what happens is the person gets lost in the arrows in between. The person gets referred, and the person never appears on the other side. And there have been numerous studies documenting that between behavioral health and primary care. There have also been numerous studies documenting problems with the referral model between inpatient behavioral health care and ambulatory behavioral health care. So what was invented then to begin to address that is Model 2, which is called the bidirectional model. You again see medical practice on the left and behavioral health practice on the right. And in this model, I think the primary action that's been taken is to co-locate services. So in the medical practice circle, you see small BH, and in the behavioral health practice circle, you see small med. And we have co-located services in that sense, where the medical practice is in one office and down the hall is a behavioral health practice, or there's a behavioral health practice and there's a medical office down the hall. And that's kind of where we are right now. This model has not fully solved the issue because even though the services are co-located, the people who are delivering the services don't actually function as teams. And that's true, I think, on both sides of the equation. You also see in Model 2 that 75% of the behavioral health patients are seen in medical practice settings, and about 25% of people with behavioral health conditions are seen in behavioral practice settings. So, Roger, why don't you describe the third model here?
Okay, but before I go to the third model, there are a couple of other components of the second model that I think are important to recognize. First of all, if you just put behavioral health people into the medical setting, it doesn't mean that they're going to be delivering the kind of behavioral health services that are needed in the medical setting. There's a different sort of practice model and a different way that you deliver behavioral health. And so it's a component of delivery as well. On the behavioral health side, when you're working in a specialty behavioral health setting, putting a nurse clinician or a primary care doc in there, the only thing that you really can do conveniently is do a history and a physical examination. But in the behavioral health sector, it's difficult to do laboratory tests, to do imaging tests, to get consults and procedures, and also to do continuity and follow-up of the medical illnesses that you identify. And a huge portion of medical care is identifying illness, treating it, and then following to make sure that the change in outcomes are occurring so that the person is getting better. So just putting somebody into the other setting doesn't necessarily solve the problem. The other thing I'd say about the bidirectional model is that we still, with the bidirectional model, are living in a separate world of payment. And so it's very difficult to support the services of qualified behavioral health specialists in the medical setting and qualified medical specialists in the behavioral health setting. So this is where we move to the third model. And the third model really creates a completely different scenario in which the behavioral health professionals become a part of the networks of clinicians that are treating the whole patient. And it's a different mindset. There's not a behavioral health world and a medical world. You're actually putting the individual patient into a setting in which both the medical and the behavioral health can be taken care of together. And this is where you get into the concept of team care that Ron previously mentioned, that the behavioral health professionals are part of the clinicians team, the team of clinicians that are caring for the total patient. The important thing, you see that there's a circle of the specialty behavioral health sector. Specialty behavioral health is not going to go away. There is a subset of patients that have serious mental illness that require special kinds of approaches to clinical care, and that will remain. And there is and should be a continuation of specialty behavioral health services for that small subset of the population that really requires special settings to accommodate adequate care. On the other hand, there's a large number of behavioral health patients that can move into the medical sector with mental health and primary care teams working together so that there is a collaboration in the care of quite a large number of not only the ones that are currently being treated in the standalone behavioral health sector, but also the many patients who are receiving no treatment that are being seen only in the medical sector and have behavioral health comorbidity.
Let me add one other comment before we go to the next overhead. And you see in this Model 3, 90% of behavioral health patients in the medical setting and 10% of behavioral health patients in the specialty setting. And in both of these settings, what we envision here is full integration, that if you go to the medical setting, you will get fully integrated care, or you go to the behavioral health setting, you'll get fully integrated care. The 90-10 distribution, in effect, in terms of numbers of people, is likely very little different than the 75-25 distribution is currently because of the implementation of the Affordable Care Act. Under the Affordable Care Act, we expect that about 39 million people eventually will receive insurance, about 20 million people through the state health insurance marketplace, and 19 million people through the Medicaid expansion. Of those 39 million people, we currently believe, based upon the best epidemiology of the early 2000s, that about 11 million of those people are people who have primary behavioral health conditions. Those people, because they will have insurance, will be available to receive services in one or the other of these settings once they have insurance, so that we can expect that both of these settings will grow here. Okay, Emma, can you go to the next overhead? Okay. So in the second overhead here, I think what's important is not that we spend a lot of time going through every box, but that we concentrate on Model 3. And I think very important from my point of view is that Model 3 will give you access to integrated care. And what will be important in the delivery of that care is that there will be fully integrated providers operating as a team. So the typical problem where a behavioral health provider prescribes one med and a primary care provider provides another med won't exist in that setting, because the group will be operating as a team. Secondly, on integrated care delivery, I think very important is the issue of not only full communication in the team, but that we will have an integrated medical record for that person going forward, so that we understand the full range of care being delivered to that person, and that the care will be fully coordinated, and that there will be continuity of care in an integrated sense as we go forward in time. Roger, do you want to add here?
Yeah, you know, I think it's real important to recognize that there's continuity both on the medical and the behavioral health side, and they are communicating with each other so that the interaction of the medical and the mental health illnesses are addressed as the primary disciplinary treatments are being given. Uh, the majority of, and sort of the next row there is payment. The majority of savings in total cost of care will be on the medical side. And if behavioral health professionals provide their services and change outcomes for patients, they're going to get none of the rewards from the better care and better outcomes that the patients have unless they are part of the general care delivery system. And so this allows them really to be a part of not only support from, but also rewards from the good service that they give. So go ahead, Ron.
You want to say a word about outcomes before we go ahead here?
So yeah, the outcomes are critical, and one of the things that in all the work that I do, I emphasize greatly is that we as behavioral health professionals, as we move into this team care approach, really need to use what I call value-added options for behavioral health. There are certain approaches to behavioral health that are more likely to bring outcomes or evidence of efficacy, and we should use those first and then go to second and third line approaches. But outcomes are critical for our patients if we're going to be effective in entering this new model of care.
Excellent. Okay, Emma, can you go to the next overhead, please? So what we put together on this overhead are you know, pulling together some of the critical features of this. So I'm going to focus here on the second bullet and the third bullet, what's being done in the context of change. From the behavioral health perspective, I think what's very important for us is that the Affordable Care Act actually includes a provision, Section 2703. And Section 2703 allows states to make application for Medicaid state plan amendments to create primary care medical homes and health homes. And there are specific populations that are recognized as part of this work. One of the populations that's recognized as part of this work are adults with serious mental illness. Another population that's recognized as part of this work are adults with substance use disorder, and then various disability populations. The benefit of Section 2703 is that it provides 90% federal funding for the first 2 years as the primary care medical home or the behavioral health home is actually built. So I encourage, if you don't know about that, to learn more about that and become engaged in that work. Find out whether your state is actually requesting a state plan amendment to its Medicaid program for one or more of these populations in one or more of the areas within your state. The other bullet I want to pay attention to is in the third bullet, the behavioral health perspective. It says dialogue, training, and practice. And there are three things that are going on here that you should be engaged in. First, on dialogue, my question to you would be, are you actually currently working with someone to develop an accountable care organization that will operate either a primary care medical home or a behavioral health home? And if you tell me no, you're not, you should begin that process as soon as possible. Those discussions are going on in your community literally as we are speaking here, and in many communities they're already very well developed. Some very good examples of accountable care organizations are the community care organizations in the state of Oregon, where the state of Oregon actually has put together 15 of these entities that are now providing integrated care delivery. On training, the critical issue here is that people begin to understand how these various practices actually work. And what kind of training will be needed in order to work in the new environment. So most people who've been trained in behavioral health care have very little training in teamwork. That's going to become much more important as we go forward. Also, many people have very little training in working in large-scale organizations. That's going to become more important as we move forward here. And then thirdly, in practice, going back to the concept that we talked about earlier of team practice, it's very important that people being trained now understand some of the new practice models that we are talking about here and begin receiving training in those particular areas.
So I'll follow on to what Ron initiated. I'll be talking to the second bullet, second part, and the third bullet, second part. So from the context of change, there's really piecemeal activity going on. And part of this really is directly related to the payment process. I mean, there's two completely separate payment systems. It's the only area of allopathic medicine in which there is a completely separate payment approach for behavioral health, and that has to change. That has to become one so that behavioral health professionals can practice in the medical setting, and medical practitioners are available to behavioral health patients as they get treated in the behavioral health sector. So when I say patchwork changes that are going on, what I see in my consulting work, and I consult to hospital and clinic systems quite often and to health plans, is that there is a recognition that behavioral health needs of medical patients need to be addressed, and that is as much for clinical outcomes as it is for cost outcomes, because of course the practitioners are now at risk for the outcomes both clinically and economically. However, the way that the behavioral health people are coming into the medical sector is that they're putting too few behavioral health practitioners with very limited service capabilities into very large primary care clinics or specialty medical clinics or inpatient settings, so that you wouldn't expect that there would be outcome change from the way that the introduction of behavioral health professionals is being done. So this really needs to come back to where the teamwork approach that Ron was talking about before. So the behavioral health professionals, as they work with and dialogue with their medical colleagues, are putting together value-added services, the type of services, both medical and behavioral, that are going to lead to improved outcomes for the patients that have comorbid illness. In order for this really to be successful, and this comes to the third bullet, we need to change from a carved out or carved in approach to payment of behavioral health professionals to one in which the psychologists, social workers, psychiatrists, nurse clinicians, and the other behavioral health specialists that are currently in separate networks now become a part of the network of providers that include surgeons and primary care docs and obstetricians and pediatricians and the like, so that behavioral health specialists are just a part of the clinical team and paid through the same payment system. So medical insurers will pay for both medical and behavioral. And this is one of the concerns, obviously, that behavioral health professionals have, that if they roll the behavioral health funds into the medical funds, that they will lose in the process. In fact, there is so much need and such great risk for the medical systems to not address the behavioral health that it's very likely that there will be an increase in support for behavioral health services, albeit some changes in the way that they're provided, i.e. in the medical setting, both inpatient and outpatient, that behavioral health will be better supported, and frankly, our patients will have much greater access to outcome-changing care.
Okay, excellent. Emma, can you go to the next overhead? Okay, we want to take a little bit deeper dive into the system we described before, and we're back again with the essential idea that 75% of all people with behavioral health conditions who are seen in the primary care sector. There are several other very important features of this that are worth pointing out. So you see 25% of behavioral health patients are with the behavioral health sector, but 95% of all behavioral health specialists are with behavioral health, the 25% of behavioral health patients in the specialty sector. Less than 5% of practicing behavioral health specialists work in the primary care setting, and the reverse is also true. Less than 1% of practicing medical specialists work in behavioral health settings. So we are a far cry from the vision that we've laid out here of how we need to change things in order to move forward. Okay, Emma, can you go to the next overhead? Okay, Roger, I think this one is yours here.
Okay, so this is a recently published report that was produced for the American Psychiatric Association with regard to the impact that behavioral health illness has on total health care service use. And this was produced by Steve Mellick, who is an actuary for Milliman, which is a large actuarial company located in, well, it's an international actuarial company, but Steve's office is in Denver. And what he was able to do was look at three national data sets, one for commercial insurance, one for Medicare, and then one for Medicaid. And he put the public program insured patients together. So this is looking at about 290 million people in the United States who are covered by commercial, Medicare, and Medicaid. And what you see from this slide is about 14% will have a behavioral health condition that is treated at some time during this, like this was 2012 data. So about 14% of the population had some kind of mental health services or diagnosis during that period of time. The total spend for that population was about $1.7 trillion. And the important part of this slide is really to look at the spend for behavioral health versus the spend that was for medical services. So if you look at the column second to the right, percent behavioral health spend, you can see that about 6.8% of the total healthcare dollars is used for behavioral health type of activity. Now, I say type of activity because about half of that 6.8% is for psychotropic medications, most of which were prescribed by primary care docs. And so there was only about 3 to 3.5% was actually provided for total behavioral health services. Now, that's a really small percent when you consider that this same 14% were using $444 billion, or 27, almost 28% of the total healthcare dollars spent for medical services. So if you look at the comparison of the amount of medical services used for this 14% of behavioral health patients, it was 5 times larger than the amount of spend for the behavioral health services, including medications. Behavioral health services alone, it's probably 10 times more, or 9 times more anyhow. So this really gives us an appreciation for the importance of the medical comorbidity in patients that have behavioral health problems. Unless you treat the behavioral health problems effectively, they're going to utilize a large number of medical services and drive up the cost of care. So this is really a message to the behavioral health practitioners such as you and I, or at least the behavioral health practitioners on this webinar, that you have a great deal to contribute in the future as far as outcomes for patients, but also improving health in the United States health system.
Oh, excellent. And these numbers are very consistent with what we know about Medicaid as well. In Medicaid, about 11% of the enrollees are mental health enrollees, and those 11% of enrollees account for about 31 to 32% of everything spent in the Medicaid program. So these overall numbers are very, very consistent. Emma, can you go to the next overhead? So we're back here, the second generation model, and we want to make a few additional points. So what you see on the top here is accountable care organization. So accountable care organization really works three levels. It works the level of providers, brings together providers into a primary care medical home. It's linked to the insurers that are funneling and channeling resources into integrated care, and the funds come from purchasers, whether they be private purchasers or public purchasers, as Roger was talking about earlier. However, the output of this system is still broken in our point of view, because if we do accountable care organizations using Generation 2 thinking, we still will be left with the disparity that accountable care organizations operate out of primary care medical homes are going to be shortchanged on behavioral health services, and behavioral health medical homes are going to be shortchanged on primary care services. Why of this? Because of separate contracts for behavioral health, because behavioral health providers remain fully independent, and patients will receive no behavioral health service in medical settings, the primary case that we made. Emma, can you go to the next overhead, please? Maybe Roger, you could take us through Model 3 here.
Okay, so what Ron and I really are suggesting as a part of the article that we wrote for the Annals of Internal Medicine are that behavioral health providers really become a part of the total health care delivery system. So the behavioral health, there would be no separate payment system for behavioral health providers. The behavioral health providers would become a part of the medical networks of providers, so there would be no separation of those, and they would be collaborating and coordinating their services in the medical setting, and they would have their standalone specialty behavioral health setting as a part of the total health system, so that the patients are not divided into the head and the body, which is really the fragmentation that patients experience every day in today's both payment and delivery system.
Okay, can you go to the next overhead, Emma? I'm going to be sensitive to time. We want to probably wrap up here in about 5 minutes. So, and this one, again, we want to leave you with the idea, if what Roger just described became true, we would have about 90% of persons with behavioral health conditions seen in integrated medical settings, and about 10% of persons with behavioral health conditions seen in specialty integrated settings. And the characteristics you see on the bottom of this overhead are the characteristics that we've been talking about. Behavioral health professionals become part of a total health team. Behavioral health is possible in medical settings, which it pretty much is not at present. We will have hopefully a sustainable payment system that we can move forward with, and our challenge here that we need to change the status quo. Can you go to the next overhead, Emma? And so we want to spend a minute on what will be involved in transitioning to this Generation 3 model. And let me just talk to a couple of the first features here, the conceptual features, and then maybe Roger can talk to the operational features. So on conceptual features, behavioral health comorbidity retards medical improvement and drives up cost in medical settings. So there's a very strong reason why we would want to change that situation to improve the treatment of behavioral health conditions in medical settings. Value-added integration of medical and behavioral health services improves health, and it should reduce cost. And Roger showed you just a few minutes ago the tremendous amount of money, $444 billion being spent on this population in medical settings. And then thirdly, clinical outcome and cost savings orientation necessary for success in achieving the triple aim. So the triple aim is something that relates to the Affordable Care Act. Three goals: better population health, better quality health care, and lower cost. And most of the work of the Affordable Care Act is oriented toward that triple aim, including the Section 2703 Medicaid state plan amendments I described a few minutes ago.
So I'm going to follow on to what Ron talked about conceptually. Operationally, it really means you, both on the medical and the mental health side, have to become actively involved in initiating this process. We are not talking about expansion of traditional behavioral health services. We are talking about the development of non-traditional behavioral health services, i.e. services that can be delivered and paid for effectively in the medical setting, which is really where the majority of mental health patients are. Now, as we do that, we need to ensure that there is adequate and appropriate support for those that remain in the standalone behavioral health sector. But we really have to develop this non-traditional approach so that on the inpatient, outpatient, emergency room, and et cetera sector, behavioral health services are just as available as surgical service or obstetric services or pediatric services and the like. In order to do this, we need to really directly recognize that the payment system impairs our ability to do that. If we have separate payment systems for behavioral health services, it is impossible to integrate the medical and the behavioral health services into a team setting, as Ron and I have been talking about today. Now, we feel that this is a time-limited opportunity that we have with the ACA, the Affordable Care Act, and the introduction of exchanges and accountable care organizations. So we really have to take concrete action and develop a timetable for doing the changes, initiate the medical and behavioral health dialogue that's necessary for that change, and then introduce these changes systematically over the next 3 to 4 to 5 years. And if we can do that, then I think that we're going to be much better on the other side of the health reform ACA activity than we currently are today.
Okay, good. And so, Emma, I think we are ready to wrap up here, and we're ready to open for questions.
Great. Well, thanks to you both. For our participants, we have about 15 minutes for questions, and so you can either enter your question into the little text box underneath questions in the GoToWebinar control panel, or if you would prefer to ask verbally, you can raise your hand and I will unmute you. Okay, so our first question is, has the medical community given a public position on Generation 3 full integrated care? They appear preoccupied with SGR and malpractice and not devoting attention to full integrated medical behavioral health care.
You want to lead off, Roger, and then I'll comment here?
Okay, I agree that there is diverting agendas that are on the table on the medical side, and that attention to the integration of behavioral health services has not reached the level of attention that SGR and some of the other initiatives in general medicine have. On the other hand, the SGR is really, from my standpoint, a time-limited. It's been a long time-limited problem, but it's something that really is more focal in nature, whereas this integration of behavioral health is a true patient need that, I think that as the ACOs are building their service delivery units, that they are recognizing now that there's a great need to better address behavioral health issues. So I think that if the medical people start talking about it and the behavioral health people are receptive and also start talking about it, I think there's a great opportunity at the current time to raise the level of awareness and the level of activity greatly in the future.
So let me add just briefly to what Roger said. When we wrote this article, we had to decide where we were trying to publish it. And we thought it very important to publish this article not in a behavioral health journal, but in a primary care journal. And for several reasons. Number one, to document that the primary care field is actually concerned with this issue, and we do believe that it is. And secondly, to also extend the dialogue about this issue outside of the behavioral health field into the primary care field. I do know, and I do participate in a lot of activities in the behavioral health field, there's considerable dialogue and discussion going on in the behavioral health field about integrated care at the present time and the various models that we have talked about here today.
Thank you. Our next question is, how do you see the ACA integration affecting mental health boards nationwide?
A very good question. Let me start off with that, and Roger, you can add to it. So that's the type of question that would come to me, and I'm currently doing a lot of work with counties and county mental health boards regarding this issue. And I think the short answer to the question that's being asked here is the fact that it's very important that county mental health boards undertake work in this area. It can be done in any number of ways. To initiate the work can be initiated by the county board in a outreach effort to local federally qualified health centers to actually begin building behavioral health services in those federally qualified health settings and building those services through direct linkage with currently available county behavioral health services. And I know many counties that are beginning to work on that model. Looking downstream from that, a much future state would be saying something to the effect, we want to build a community collaborative that is going to promote good integrated care across our entire community, not only for the public sector, but also for the private sector, and then bring about partnerships and dialogues across all these partners that are available in most communities to undertake this work. And I would say that the primary responsibility for initiating those types of dialogues occurs with the county and community boards that the person was asking about.
So I'm gonna answer this in a little bit indirect way. We're in a time of change. Change is never easy for anybody. Ron and I really got together to write this article because both of us recognize that in our own areas, there are patients that are getting ineffectively treated and getting poor care. Both on the behavioral health side, they're getting inadequate and ineffective medical care. On the primary care side, they're getting inadequate and available behavioral health care. And what we're talking about is becoming a part of the dialogue and recognizing that anytime there's change, there's risk. But we're really working on behalf of the patients that we represent and that we care about. And if we don't change, we're going to be as bad as far as delivering behavioral health care 20 years from now as we are today. So we really need to initiate changes, and this is a time where we can really do some tremendous changes for the patients that we care about. So with regard to the boards, this is true not only for the behavioral health boards, but also for the boards that are taking care of the community medical centers and the primary care clinics. You have to be thinking in terms of introducing behavioral health services, so it's a bilateral initiative.
Excellent.
Thank you. Next question is, what is the status of government and non-government payers' receptivity to Model 3 Unified Payer Integrated Delivery System approach?
Let me start off again. So when I mentioned Section 2703, and Section 2703 is part of the Affordable Care Act. The purpose of Section 2703 of the Affordable Care Act is to foster the development of primary care medical homes and behavioral health homes that do what we have described in Model 3. And to incentivize that, it provides 90% federal funding for the first 8 quarters of the state plan amendment to help these programs get up and running. And it provides resources for care coordination, IT, all the necessary things that you need to bring together in order to make this a going concern. So I would say in terms of federal policy strongly supports Model 3 the way we have described it. And in various states, let me cite California. So California, as an example, would be a state that is now going through the type of development somewhere between Model 2 and Model 3. So they are undergoing integration at various levels. So the state mental health agency and the state substance use agency are no longer independent. They become part of the state health agency. Just very recently, the County Mental Health Directors Association has begun work to integrate with the County Substance Use Directors Association. The California Institute for Mental Health is integrating with its peer organization to do policy work and research. You see changes going on at the policy and organizational level that will then positively impact on the implementation of Model 3 at the community level.
And I'll just follow up with Ron's comment in saying that there will be inconsistencies of how this is rolled out. I mean, in some situations, it's going to be commercial that is taking the lead and doing a little bit better job than the public insurers, and on the other side, there may be some things that come out of the ACA with the MSSP shared savings program that are going to create a process that leads us quickly to a more integrated approach. Regardless, I think that it's important that we all have a vision of where the future should go. And that's one of the reasons why Ron and I put this into a graphical format so that you can actually visualize what it might look like, because ultimately we want to be there at the end of this sort of rough transition process that we go through.
Excellent.
Our next question, we're doing integrated behavioral health as our center. The challenge we face is that in California, if you provide medical and behavioral health services on the same day, you only get paid for one. Any creative thoughts on that? A lot of times patients don't want to come back for behavioral health services on a different day.
Okay, so an excellent question again. And so there are several levels of answer to that. There is absolutely nothing in federal law or federal policy that prevents the payment of a behavioral health and a primary care visit on the same day. Having said that, in many states, the state auditing procedures for Medicaid are set up so that the system tilts when it detects a primary care visit and a behavioral health visit on the same day. So recognizing that there's a disconnect here between federal law and policy and what the states are doing, there's a major effort underway to reconcile these things. And so I know that the Center for Medicare and Medicaid Services at the federal level is working with virtually every state on this issue as we speak to resolve that problem. And that problem is something that has plagued this work for at least the last 15 to 20 years. The best I can say right now is the problem is being worked on, it's recognized, and will ultimately be resolved, basically.
I don't have anything to add. I think Ron did a great job.
Great. Where do community-based, non-medical behavioral health services and supports, such as peer-provided services, supported employment, and psychiatric rehabilitation fit into this integrated service model?
Oh, again, a wonderful, excellent question. So when we talk about integration, either from the behavioral health side or the primary care side, I think we need to and could expand and write additional papers about the exciting new role of peer support in integrated delivery systems. And I myself have written some commentaries on that if people are interested. And I envision that peers will have whole new roles that they don't currently have working in integrated delivery systems operated through primary care settings. And one of the new opportunities for peers is working with patients who actually do not have any behavioral health conditions. And what we're doing right now in the field is actually developing a language to talk about integrated peer support as something very new in the field and very exciting. The other part of the question was about social wraparound services, job supports, housing supports, social supports, and so on. For many of the people Roger and I are talking about, it is not possible that medical care or behavioral health care per se will be effective if we don't also assure that these people have available appropriate job supports, housing supports, and social supports. That's why, as we go forward, it's so very important that the funding that's been available through the mental health block grant and the substance abuse block grant be transformed into money that can pay for social wraparound services. Similarly, as states begin to engage in the Medicaid expansion, it's very, very important that the current state general revenue that pays for these populations not be taken off the table, but be converted into social wraparound service. So an excellent question and a very important feature of what we're talking about here.
So, and I'd just like to add that it's not only peer support, but it's also case management. It's going to be a major contributor in the future. And this gets into sort of facilitating the wraparound services that are very important for patients. And I guess I'd like to just point out there's a tendency for people to think of mental health patients as having different needs from medical patients. They're the same patients. Everybody needs to have the peer support, the case management, and the wraparound services. There's no difference because these patients fall into the same bucket. So there are many things that are going on with greater emphasis in the mental health side that are just as applicable and important to incorporate in the medical side as we do on the behavioral health side. So I think there's a lot of collaboration and learning that each side can get from each other.
Great, and we're out of time for questions today. Thanks so much to both our presenters and for all of our participants joining us today. I hope you're able to join our next webinar on May 14th with patient advocate and author Carrie Sparling. Thank you.
Emma, thank you very much. We enjoyed it.
Thanks, Emma. Bye, Ron.
Bye.